Good morning to those of you who are on the West Coast. Good afternoon to those of you who are on the East Coast. My name is Lydia Isaac, and I am the Vice President of Health Equity and Policy here at the National Urban League. And we have started this health equity webinar series in January to really provide information and thought leadership on issues in health equity that are happening around our country and in our Urban League movement. I'm really excited about the panel that we have today. And for once, I don't have to moderate everything. We have a fantastic moderator, which is Marcus Johnson, who's the president and CEO of the Urban League of Springfield, Illinois. We also have three distinguished, wonderful, actually all personal friends of mine that I love, panelists, starting with Samuel Baxter, who's going to be an assistant professor at UNC Chapel Hill, Darrell Hudson, who is an associate professor at Washington University, St. Louis, and Thomas LaVeist, who I will say is also my dissertation advisor and mentor, who is the dean of the Tulane School of Public Health and Tropical Medicine. I'm going to hand it over to Marcus, who is going to moderate this wonderful discussion on Black men's health, and I hope that everyone enjoys it. Everybody had the bios that are in our invitation, so we're not going to go through everybody's bios, but feel free to use the question and answer function in the webinar to ask questions, and we'll leave some time at the end for folks to ask questions. So please enjoy. Marcus, thank you so much.
Thank you, Dr. Isaac, and good afternoon again, everyone, and welcome to our June 2023 Health Equity Webinar Series, where we are discussing the critical topic of Black men's health. As shared in typical fashion, we encourage all of you watching to get involved in the discussion too. Use the Q&A, please. We encourage all of you watching again. Please feel free to submit your questions using the Q&A box in Zoom, and we'll do our best to address them during the audience Q&A portion towards the end of the webinar. So with that, let's jump in. Our first question is a broad one. What is the current profile of Black men's health in America today? How has this profile changed over time? Are there specific critical or urgent health issues that need to be highlighted? And do we see any differences across the country? Dr. LaVeist, New Orleans is a melting pot of people and culture. The city has such a diverse mix of backgrounds with influences from Europe, Latin America, the Caribbean, Africa, and many indigenous peoples. And given your extensive research and significant work that reaches Black men both nationally and globally, would you like to kick us off with today's conversation? I'll repeat it again. What is the current profile of Black men's health in America today? How has this profile changed over time? Are there specific critical or urgent health issues that need to be highlighted? And do we see any differences across the country?
Yeah, well, thank you. Thank you for that question. And thank you for this invitation to participate in this important discussion. The profile of Black men's health nationally, I think, is not very different than it has been certainly throughout my career. You know, Black men have lowest life expectancy, I'd say, of any gender and racial group in the United States. You know, there's some caveats around that, which we can get into if you like, about some other populations, such as Pacific Islanders, who are not well captured within federal data sets. So, you know, so I'm somewhat hesitant to say the worst health profile, but certainly in terms of what we regularly document in this country, Black men have the worst health profile, the lowest life expectancy, higher rates of most conditions, both chronic conditions, as well as injuries, accidents, infectious diseases. So I'd say that overall, Black men, men in general have worse health profile than women, but Black men, I'd say, would have probably the worst health profile among men.
Of those mentioned, which do you believe would be the most critical or urgent for us to respond to?
Of which condition?
Yes.
That's a really hard one to say. I mean, I think that you can look at different ways you can look at that. One way you might look at it is kind of what are the biggest killers. Another way to look at it might be what are the conditions that sort of lead to other related conditions. So if we look at it that way, I'd say, you know, hypertension and obesity certainly are the gateways to many different causes of death, all of which are high for African Americans. You know, we have cardiovascular disease or heart disease, cancer, you know, diabetes, stroke, all related to hypertension and diabetes. So I think you'd have to say that those two conditions are hugely important. But I think you have to also look at homicide. We have very high homicide rates among Black men. And that really is more socially determined of what's happening there, over policing in Black communities and over aggressive policing in particular. So I find it really hard to say what is the most important issue. I think all of these are important and all of these need attention.
Excellent. Dr. Baxter, did you have anything to add to this critical conversation point?
Sure. I think a few things I'd like to add to echo. I think one thing is what's changed over time. I think the story has kind of stayed the same, but due to the recent COVID-19 pandemic, we've seen, Black men take a major hit, and Black communities in general take a major hit with that in terms of life expectancy. During the COVID-19 pandemic, life expectancy for the United States actually decreased. It became the third leading cause of disease during kind of its peak. But with Black communities and Black men, we actually suffered the greatest years of life loss, 2 years in life expectancy reduction. So COVID-19 is something that's changed, and we aren't sure, what'll be the next new thing that might come up. But I think we're now realizing that we have to think about, a global issue and how it relates to health in America and does that mean for a Black population and Black men specifically. And then I think drug overdose is starting to become a new peak and a new wave that we really have to think about intentionally and to address as we think about important and urgent health crises among Black populations. And of course, that ties to mental health, and different coping strategies, whether they're helpful or harmful for Black men's health in particular.
Excellent. And thank you both, Dr. LaVeist and Dr. Baxter. As you both mentioned, it's critical that we don't overlook the broader context within which health disparities arise. So I want to pose this question to the panel. What are the key social determinants of health that are impacting the well-being of Black men? Essentially, what are the inequities and injustices that impact Black men's health? Dr. Hudson, could you take this one?
Yeah, sure. I think social determinants of health are absolutely critical and undergird so many of the conditions that the other panelists have laid out: overall life expectancy, emergent diseases such as COVID, chronic diseases, you name it. A lot of this boils down to, in the United States, to structural racism. So where people are living, what access to health promoting resources do they have or not, issues over the life course, education, employment opportunities, transportation. All these things, unfortunately, are grounded in where people live their lives, so where they live and play. And so the more we can do to disrupt that relationship, I think the better outcomes we'll see. Everything from where healthcare is accessed, so going to see a physician, again, where you can get a reasonable opportunity to make something of yourself, employment opportunities, so on and so forth. And as Dr. LaVeist mentioned, some of these broader outcomes like homicide, for example, a lot of those things are born out of lack of opportunity. Unfortunately, a lot of that goes back to structural racism, again, redlining practices, restrictive residential covenants, and those types of things that are in history, but certainly have impact on contemporary outcomes.
Excellent, excellent. I absolutely agree. Dr. LaVeist, did you have anything additional to add?
Well, I mean, not much to add. I mean, I think what he's saying is right. I mean, the social determinants, I think there's social, political, and economic determinants. I think they're all there. And I've often said that there really are 4 disparities. We talk about health disparities, but there really are 4 disparities that I think are connected in a way that we really cannot disentangle them. And there's health disparities, there's wealth disparities, there's educational disparities, and there's criminal justice. And when I say criminal justice, I'm talking about mass incarceration and over-aggressive policing. And I think that, I'd say that those other 3 elements are the things that are really driving the health disparities, and the health disparities are driving those other elements. They're all causing each other. And that kind of web of causation is the problem, that we find ourselves in that loop and we can't get out of it. And the only way out is through politics. So the political determinants are also critical. So for example, I think a clear case of a political determinant of health is, so the Affordable Care Act is passed by the Obama administration. And as part of that, states are given the option of expanding the Medicaid program to cover more people. That expansion is being paid for almost entirely by federal tax dollars. But if you look at the states that have refused to expand, they are the states with the largest Black populations. They are the states in the Southeast. So while the Affordable Care Act had the potential of dramatically increasing and improving access to healthcare in this country, it has done that, but it has not done that nearly at the scale that it could if states that refuse to expand, which are the states with the largest Black populations, would actually do that expansion. I'd also point out that the residents of states like South Carolina and Georgia and Alabama and other states, in Arkansas, Texas, residents of those states pay federal income taxes, and that's the resources that are used to pay for the expansion in states like Louisiana and Maryland and New York and California that have expanded. So they're paying for the expansion in other states, but they're not getting the benefit of the expansion. And this is political, and I think we have to also incorporate the political aspects here as well, and not just the social determinants.
I completely agree. Advocacy is key, especially in public health. I know in my schooling, I'm sure you all talk to many of your students in your conversation about this as well, but advocacy is the first step towards sustained health outcomes. It's breaking those systemic barriers that exist, and a lot of that is done through the advocacy work on local levels. What should leaders across the Urban League movement and those who are on the call do today when we look at advocacy work? You know, what should we be doing? What's the first step in our public health advocacy?
Can I take that one? I don't want to dominate the conversation, but this is one that I really want to say. We have to, so we have laws in this country, most of them state laws, that prohibit people that are convicted of felonies from being able to vote, even though they have paid they have served their sentence and paid their dues to society. These laws are unconscionable and immoral. If a person has committed a crime and the person has been convicted and punished and they have served their time, whatever that punishment is, they should be able to receive their full citizenship back. But these laws greatly diminish the Black voting power all around this country. So while you look at states like Mississippi and Alabama and Louisiana that have these very large Black populations, a large number of people are not eligible to vote because of laws that make them ineligible because of felony convictions. And often the felony convictions are the result of over-aggressive policing and other, in some cases, police mischief that people, or decisions to prosecute in cases that maybe wouldn't have been prosecuted in other jurisdictions. So I'd say that advocacy around reclaiming voting rights is critical if we're going to impact the political determinants of health.
I would also include expungement as a public health program. I know we're going to get into that in a little bit later in the conversation, but how are us as Urban League affiliates looking at expungement as a public health response? We'll move on to the next question. But thank you both for your perspective, for your commentary. Now it's also important that we remember that while we face considerable challenges, there is also a great deal of resilience and innovation happening in communities. So let's switch gears slightly, and I'll let into this a little bit. Can each of you provide examples of successful programs aimed at promoting and improving Black men's health? Dr. Baxter, could you kick us off with this?
Sure, and I like this question in this segment of our discussion, because I think we have to always remember that there is work being done and there are always gains and strides being made. No matter how unsurmountable the odds may seem, there's always people working on the behalf and betterment of Black populations. And so I know there are a few that others will probably highlight. So I wanted to just maybe highlight some more, I think, novel and kind of in vogue particular programs and initiatives. So first, I think, because we're now moving more into a digital and online society, I think digital campaigns are important. So I wanted to shout out the organization Black Health, which is based in Atlanta, founded by Black NPH students. And they actually did a partnership with Cottonelle and the Colorectal Cancer Alliance to provide a financial assistance fund to allow Black people to get screened for colorectal cancer. And so, I think, as we're going into this new movement of online activism and advocacy, I really want to kind of shout out that particular digital campaign, because as we know, cancer is a major issue amongst the American, but also in Black populations, and colorectal cancer especially, as we've been thinking about what it means to be a man and the ways that you might get screened for colorectal or also prostate cancer, for example. So I really appreciated their initiative, being very inclusive and partnering with some major funders to not only focus on the educational piece, but really that financial assistance piece, which I think, as we've talked about, social determinants of health and economic gains, and even medical debt, for example, just helping them kind of get over that first hurdle to get assistance with that. I also want to shout out the YB Men Project, which is led by Dr. Daphne Watkins. And this program essentially really promotes manhood, mental health, and social support, which I think is really important as we think about Black men's health and ways that we keep them connected and integrated and healthy and whole. And I want to also acknowledge that this particular intervention that she does around masculinity and manhood, it actually started with college age groups, but now it's been adapted to high school and middle school populations. So really going kind of more so in this life course trajectory around healthy mental health practices and masculinity and social support for Black males.
So thank you for sharing those resources. I'll try my best to make sure we get those in the chat box as well. Dr. Hudson?
Yeah, sure. I think those are great programs to mention. I think in general, it's important to know your local backyard. So what's happening. So I think chapters across the country, I've always had a great deal of respect and admiration for the work that the Urban League does. So I think locally, people know what's best, what the needs are, and most importantly, to the question that you're asking, know where the resources are, where the strengths are within communities, what organizations are doing work. So I can run off a list of things that are happening in my backyard in St. Louis, but the common thread that I would say for organizations that are doing really important, impactful work is the main thing is that they meet people where they're at. Whether it's in barbershops, so doing health promotion in barbershops, bring people health education, showing them different ways to prepare meals, showing them that folks value them. I think it's another place of connection. I think Dr. Baxter mentioned that as well. Social support is one of our most important aspects as human beings across the board. The ties that bond us are incredibly important. And so having safe spaces where men and other people can come, whether you're talking about the NBA draft, whether you're talking about stresses in one's life, troubleshooting, sharing resources. So again, meeting people where that, it can be a barbershop, it can be a rec center, it can be a frat house, a lodge, whatever the case may be, showing up where people are at. I think that's really important. I think co-location of services is also really important as well. So oftentimes we think about healthcare sort of on its own island, but the more we can integrate other services, so social services, housing issues, legal services, employment, father support centers, et cetera, the more we can co-locate services into one place. So if one person can go to a one-stop shop, for lack of a better word, I think that's another important thing to do. And I think there's other advocacy organizations as well. So I think someone mentioned cancer awareness and prevention, organizations that provide support in terms of raising awareness, bringing screening to people, again, meeting where they're at, advocating for them at the local and state level to get changes made so that the affordability of care is better. I think those are really critical things. So that's why I would say meeting people where they're at, no matter where you're located around the country.
Tulane, WashU, and UNC reach some of the most prominent and up-and-coming public health practitioners. In your discussions that you're leading and in the conversation that you're having with many of your students, is there an intentional focus or desire on behalf of the students to talk about mental health or trauma-informed care specifically around Black men?
Well, I think that there's certainly been a movement towards trauma-informed care and public health. We've seen that here. I think I've seen it around the country. That certainly has gotten a lot more prominence in the last, decade or so within public health, and I think it's critical. I think probably every school of public health at this point is teaching in their teaching programs is addressing trauma-informed care. I haven't seen it specifically addressing Black men, however. I mean, I'm not seeing much of an emphasis on that within the field. One of the issues we have in public health is that we actually get so few men even going into the field of public health. It's becoming, at least certainly over my career, it's become more and more female oriented. We've seen this decline in the number of men in college in general, but certainly the number of men going into public health. So I think the issues that are most pressing for men don't get as much attention, in part because fewer of us are going into this field.
And I think there's also a need to connect across differences, right? So especially as we think about more awareness in our public health curriculum on LGBTQIA+ rights and health concerns, attaching those to, for example, men's health issues, to Black communities and populations. So it's not, I think, always about focusing on one group, but being inclusive of others and finding those areas where we can kind of be touching in tandem.
Yeah, and I'll bring up the rear and just say, so where I'm at is kind of unique. Our public health program is in a school of social work. It's probably one of the most unique fits in the country. So I think we see a lot of students who have dual interests. So students who are social work students and PhD. Social work is a sister field of public health, and you see quite a bit of attention to training around trauma-informed care. So even if people are not endeavoring to become a joint MPH, MSW student, I think one thing that I've learned in my career as a public health person is borrowing from some of the things that my social work colleagues do in terms of trauma-informed approaches. Being aware of the history and the political context of local communities, understanding the challenges that people face, understanding that, it's not enough to give people information about how to promote their health at the individual level without understanding the context that people are in, the stresses that they're under on a day-to-day basis, how that stress, informs brain development, academic achievement, chronic disease development, so on and so forth. So it's really, really broad and important to understand the trauma at a community level. Simultaneously, it's also difficult to balance that out. So the question you asked before that, Mark, is about what are some of the strengths that are embedded in communities. So one thing that I do notice that students push back on is sort of this pathologizing of communities. So without any sort of, acknowledgement that their strengths, and people have thrived in communities regardless of whether people in academic institutions have paid any attention to them whatsoever. So I think it's important to, again, balance it out, make sure that people understand what resources are there, understand where the strengths lie, and also understand what are some of the challenges. Oftentimes those are, as Dr. LaVeist mentioned, those are politics, those are political, that are upstream, what we call upstream determinants that may go beyond the individual level.
Thank you all for your commentary. Health is wealth. I mean, speaking to you all know this very clear. Diverse opinions, voices, and perspectives makes us all, makes every discipline stronger. And so I want us to highlight or ask one question really about how do we encourage more men to see public health as a field of interest? I mean, for me and my background, I wanted to be a doctor. My goal was to be an anesthesiologist. But the public health side of healthcare was very interesting to me, in that I was able to see more immediate changes by speaking to behaviors and attitudes and developing strategic programs that respond to and support doctors of all practices. So what can we do to really ring the bell for men to see public health as a gateway to any business industry or field or career aspiration, that public health could really be, that program, that discipline of study to support those long-term changes?
I guess I'll go first with this question. So I think Dr. Hudson already mentioned that public health borrows from a lot of disciplines. And for someone who, for example, started out in sociology, in undergrad and then transitioned to public health for my master's and then health policy specifically for my doctorate, really finding and always being exposed and open to new ways that public health does touch so many things. If you're interested in politics, there's a way for public health and to really focus on the health of politics, for example. If you're interested in education, there are ways to think about educational practices and curriculum and training and development. So there are many aspects and avenues that you can take and use public health degrees and disciplines to inform your work. But I think ultimately it comes back to representation and showing many different facets of public health. I have friends who work for government. I have friends who work for NGOs. I have friends who are doing consulting on their own. I have people who are in community and private sector and who work for the CDC. So there are many avenues to use a public health degree. I think thinking about people who want to do applied work, I think is important to give them that option for public health as a possibility.
Thank you all. Thank you all for these really practical suggestions for us. I want to end on the visionary note, and I'll keep the conversation going, but if you had unlimited resources, what would be the #1 action you would take to improve Black men's health? Let's start with Dr. LaVeist and then go to Dr. Hudson and then Dr. Baxter.
Unlimited resources. If I had unlimited resources, well, I would give everybody a job with a living wage, and I would have a national health insurance program that would make every citizen eligible for getting access to healthcare. And I think that if we did that, then Black men would do the same thing everyone else does, which is they'd get a doctor, they'd go to the hospital, and they would use their health insurance. So I think that's where it comes down to. It's really about the economy and the fact that in this country we tie access to healthcare to employment, and it's a bizarre thing that's only done in this country, and only in America do people accept that somehow you have to be employed to get access to healthcare. But I would fix that problem, and I think that would be the place I'd start.
Yeah, I would build off of what Dr. LaVeist mentioned there in terms of the importance of economics. I think if you're talking about Black American health, especially Black men's health, there's two things that I would try to do. One would be disrupting the relationship between zip code and health. Oftentimes we say now zip code is more predictive than genetic code in terms of longevity and quality of life that people have. So I would try to do what I could to disrupt that. That might mean strategic investment in different communities. So pouring of money and other types of resources in certain communities. You know, I think the other big thing, and this is probably controversial, but maybe not for the Urban League, would be thinking about different reparations programs. I think that Dr. LaVeist mentioned it earlier, like wealth is absolutely critical, especially as it relates to health. On average, I think the average Black household has like 5 or 6 cents of wealth for every dollar of wealth that a white family has at the household level. And so these wealth inequities didn't come from lack of thrift and hard work. They're embedded in policies, not just in terms of slavery, but also the New Deal era policies and how these policies were inequitably distributed. And lots of Americans don't know history. They think this stuff is way back in ancient times. And now the differences we see, especially with regard to wealth and health and other outcomes, are all due to poor decision-making, people not working hard enough and making good decisions. But I think, again, disrupting the association between place and health will be critical, and the provision of actual real wealth to people would make a big difference.
And I guess to round out, I mean, they hit all the things. I want to echo once again, allow felons to vote. But I think what we're ultimately talking about is ending structural racism and dismantling it. And I think because half of the Black population in the United States is concentrated in the South, I've been born, raised, and live in the South. I would say focus all of those efforts, especially on the South, where we're seeing a high concentration of Black population and where we're seeing a lot of the racial disparities exist. So yeah.
Dr. Baxter, can you build on that a little bit for us? institutional racism embedded in public health strategies is really starting to trend across the country, especially for minority-led organizations and community-based movements. So how does institutional racism contribute to health disparities among Black men? What can we do strategically to address it?
Sure. That's a big issue. That's a big problem. I think one thing is realizing that we are often going to institutions, right, that may have explicit or implicit allegiances with a white racial frame, which essentially views white people's lives as mattering more, white people as being the norm and others are not the norm, as opposed to this advantage, disadvantage, privileged versus oppressed kind of thinking. So first, acknowledging that and knowing that all of our answers won't come from institutions. I believe in grassroots work. I believe in community building and mobilizing and allowing those who are closest to the issues, who are often at the margins of the discussion, to be the ones that we should be centering in the conversation and finding the directions on what to go with. I do a lot of work right now in rural South Carolina, and I have been kind of doing that for the past few years during the pandemic. And ultimately, I'm always like, let's talk to the people who are there. What do you need? And then think about how we can leverage our resources to meet that need. I think there's often this assumption that people who are experiencing health inequities may not know what to do, but they do, and they also know what the issue is and also how the problem should be fixed, but it may not be within their power to fix it. We've talked about big issues of economics, for example. If they need more jobs, they may not be able to create the jobs, but institutions can find ways and programs and initiatives to reinvest economically in communities. So I think ultimately it's institutions realizing that they are not the ones who should be always directing the action, but listening and then leveraging their resources to really do the actions that build the communities up.
Excellent, thank you. Thank you very much. Dr. LaVeist, did you have any additional commentary?
Yeah, I think structural racism, we're placing a lot more emphasis on structural racism of late, and I think that's very much appropriate. When you look at the work on race and racism and health that's been done, we first started really talking about what I call interpersonal racism or bigotry. You know, people with negative attitudes towards Black people, right? And that's where we kind of focus at first, looking at the relationship between being exposed to that kind of bigotry and health, and documented. A lot of studies are documented. I've published them, and others on this call have, and documenting the relationship between the exposure to that sort of racism and health. Now we've moved to institutionalized racism, looking at how institutional structures were set up in such a way that they intentionally produce inequitable outcomes. And I think that's important. The area where we really have not focused yet, though, in the research, and I challenge my colleagues, to start really thinking about this, is internalized racism, which is a little more of a hairy nut to crack, a little more difficult to get into because of concerns about blaming the victim. But the fact is that a distrust or disrespect of Black people is an American value, and African Americans are Americans too. And some of that is in turn embedded into our culture as well. And I think that we do have to begin to look internally at our own community and start looking at the aspects of our community that may also be contributing to the relationship between racism and health by virtue of internalized racism. I know a very kind of tenuous topic to get onto, and an uncomfortable topic for us to talk about, but if we're going to really make progress, we're going to have to engage that as well.
Absolutely. I appreciate you all and the insight and examples you provided, especially around the public health utopia and how we can create a more equitable society. Spending the conversation to really look at National Urban League affiliates like the one that I lead in Springfield, Illinois. What is one thing that we can do in our local communities to promote and improve Black men's health? One program, one idea, one strategy, one takeaway. We end the call today. What can we do in our respective silos or communities to really improve Black men's health? Dr. Hudson?
Yeah, sure. I would just reiterate some of the things that we said. I think Dr. LaVeist's point about voting, restoring the franchise to people, turning people out, I think that's absolutely critical. And that is a public health I think one of the things I always think about in terms of advocacy is do what you can where you're at with what you got. And so I think that no matter whether you have MPH or whatever degree, whatever background you have, you can certainly help turn out the vote and advocate for people to have their voting rights restored. I think again, meeting people where they're at, providing services and spaces where people congregate, especially Black men. I mentioned a few places before: barbershops, lodges, it could be pool halls or bars, wherever the case may be. But I think one of the challenges right now is people, especially within public health, have oftentimes tried to build sort of connection points within churches, which is great and wonderful. But we all know that a lot of Black men don't go to church. So you got to find where they're at. And so I think that figuring out where people are, and sometimes that means engaging the local community and asking people, like, where do people get together? Where are some big events? How can we provide services on the spot, bringing services, education, et cetera? So I think those are some things that any local chapter, local affiliate can do.
Excellent. Are there any others?
I think that Black men need to, one thing that I think we can do is that Black men can ask other Black men, how are you doing? And not accept I'm good as an answer. How are you doing? And get people to really open up and engage with kind of what's happening with them. As men, we are trained from the very beginning of life not to present any weaknesses, or not to acknowledge any deficiencies or any problems that are happening, that we should just man up and suck it up and just, plow through. And this is killing us. And until we as men start engaging with the fact that we are humans and we have frailties and we have limitations and that we can be sick and that we can't simply will ourselves into good health, and we start actually talking to each other, until we start doing that, I don't see how we're going to make progress there. So I think kind of some thinking about, what do we mean by manhood? And does manhood mean that I can't tell you, hey, I just got a diagnosis that, I'm diabetic? I can't share that with you. Or if you do have a friend that is a diabetic, you ask them, well, when was the last time you checked your A1C levels? How are you doing? Are you staying up on that? If we really care about each other, we should be asking those types of questions. And until we start doing that, I think we're going to continue doing the things that we have been doing, and those things have led us to having the lowest life expectancy.
Thank you for that comment. I always think of self-care. Often we hear self-care, but it's never really focused on Black men's perspective. It's never the visuals, even the tools and tactics are not traditional things that you would associate Black men with just doing. So how do we change some of that narrative too? How do we identify role models that aren't just athletes to increase our awareness or our ideas of looking at self-care as a part of our response to poor health outcomes?
I think that there are many ways that Black men engage in self-care, but again, to Dr. Lewis's point, we don't talk about it. So I think the Urban Leagues affiliates could provide more spaces and opportunities for Black men to congregate and get together. I know Dr. Hudson talked about places where Black men coalesce, but we still need more. Those might be places that I only feel like I can go on the weekend, right? And if I have a lot to do on this weekend because I've had a tough work week, or I have to, take care of a responsibility, I miss out on that opportunity, right? So providing more of these opportunities and spaces for Black men to get together and to engage in what we're talking about is social support. And there are many ways that we receive social support, but we may not be calling it that. Even if you have the friend who just always cracking jokes, right? Who will not get off the phone or will not leave you until, you're both laughing. Like, there are different ways that Black men do promote care for each other. And I think just calling it that and allowing those ways to be acceptable, even if we don't have a label for it.
I agree. Black manhood comes in many shapes, sizes, and identities. And so it's important for our responses as Urban League affiliates to be as inclusive as possible while understanding the many, many differences and nuances of Black manhood. So thank you all. One of the things that was mentioned really briefly, and I bring this question up because it's what really often turns into the response of Urban League affiliates. It's education and then preventative health screening. So how can we increase the engagement of Black men in preventative health care and regular screenings? We've heard of the barbershop approaches, but even those brick and mortar institutions where we've grown familiar with have been impacted by COVID-19. Instead of waiting in a line at the barbershop with many, many men and women waiting to get a haircut, we schedule appointments online and we go into the barbershop, and in most cases, it's me and the barber. So it's not the congregation of men to have these conversations that we're hoping for. What else can we do, to really increase the engagement of Black men in preventative health and regular screenings?
Yeah. Well, the barbers, I think the most effective barbershop interventions are the ones where the barbers are trained to have those types of conversations, right? So even if there aren't other men in the room, you can still have that one-on-one conversation, which in some ways might be even better because the client can then get into a more personalized conversation. But I definitely encourage that we continue to use those types of strategies. Here in Louisiana, we have an organization called the Ashe Center where they train culture bearers on health education, health messaging. So musicians, Mardi Gras Indians, Mardi Gras crews, things like that, to people to have those kind of informal conversations in real world settings. I think more of that, is important. But as a community, we just need to start understanding that it's okay. It's okay for me to say, well, Samuel, how you doing? What's going on? And if he just gives me the, oh, I'm good. No, how are you doing, Sam? What's going on with you? And kind of press the person and make them understand that, no, I'm asking you a real question and I want you to tell me how you are doing and I want to engage with that. If we start to do that with each other as Black men, which we don't do enough. I do have some Black men in my life that do that. And I do that with some others, but we need to do more of that. And I think that needs to become a part of our culture, that we actually engage with our friends, in this kind of way, and actually promote the idea that, it's okay to talk about how you're feeling. It's okay to talk about that you may be at an emotional low point or something's happened in your life with the people that care about you. I think that's a critically important thing that we need to change about the way male culture operates. And this is male culture. It's not just Black male culture, but it certainly is Black male culture. And I think within our culture, we need to start moving beyond that and start getting real with each other.
Excellent. Thank you all for sharing your thoughts and insights on these pressing issues surrounding Black men's health. Your expertise and passion have shined through in all of your responses and recommendations. And if no one feels empowered to move, I'm empowered. It gives me hope for a future where health equity is a reality for all. So I do want to take some time before we end our hour with looking at questions from the audience. It looks like we have 2 in the chat box that I would like to pose to you all. The first one, from Dr. Stacy Grundy. COVID really highlighted health literacy challenges in our community. What strategies do you all recommend to improve health literacy among Black men?
Well,
I think now, go ahead.
I'll just,
Dr. LaVeist.
I'll bite off what Dr. LaVeist laid out there before, which is how can we train like lay health providers or lay people who might not be in healthcare at all to promote messages? Because oftentimes I think, to me, it's not just about health literacy. Obviously, if you go into a interaction with a primary care physician or other type of provider, and they give you a chart and you don't understand what's going on, that's one type of health literacy. But I think especially with COVID, what to me was highlighted is there's a tremendous level of mistrust. And where people get their information from is, the internet and technology is wonderful. There's a lot of promise and there's peril too. So people can go into information bubbles and to have access to accurate information. And sometimes people will argue with their providers. I know a great deal of providers who said during the pandemic that they didn't want to be told to get the vaccine. They felt like they were being browbeat or meeting patients who came in because they had these notions that the pandemic is nefarious, the vaccine and these other mitigation techniques are nefarious, and this is not that bad. This is a ploy, et cetera. So I think we have to, Dr. LaVeist mentioned earlier, we have to take a hard look within as well. And I think that changing or at least building the capacity of some of our workers, people who are barbershop or barbers, people who are pastors, et cetera, to promote positive messages about, especially, when there's something emergent that is spreading rapidly, like the pandemic we just can't, we're still in, essentially. I think that's another critical way to think about that challenge.
And what I wanted to add to that is I think messaging around the COVID-19 pandemic was a big public health failure. I think one thing that we didn't do a good job of communicating to the public is this is an evolving and an emerging issue that we continue to learn new information about. As I think about information and health literacy, I think about number one, knowledge, right? So like, what do I know? What is my capacity to retain and then kind of repeat correctly and accurately new information? But then if we think about where do we see our information from, there's, perhaps more credible health people in the health space that we may not feel is a trusted resource, right? So they might have the credibility, but we may not trust them. There may be others that we trust to get information from, but they may not have the credibility or credentials to provide that information. So giving more opportunities for good information to be disseminated. I know, for example, in my training, we talk about always being in relationship with policymakers, right? And so if a policymaker is not educated about a topic, we'll be the person, who has the information accurately and pass it to them, and they're the person people are listening to. We don't really do that on social media though, right? Providing accurate content to people who we know actually have large followings. Or, so I think thinking through it a little differently, knowing that I may not be the messenger, but I can give accurate information to the messenger, I think is an important thing that we need to start doing to kind of address this issue.
Absolutely. Key messengers and identifying who those people and those places are in our communities is critical. One question that came in regards to COVID was, I am concerned about the younger generation regarding immunization. Any recommendations?
Yeah, I'm really concerned about that also. I was I was the co-chair of the governor's task force here in Louisiana on COVID. And so you can imagine some of the conversations I had with people. It's pretty shocking, and it's a real challenge. For some reason, many people are more afraid of the vaccine than they are afraid of the virus. While the virus killed millions of people, the vaccine hasn't. I think to kind of address what Dr. Baxter was just saying. A lot of these influencers in social media were intentionally putting out inaccurate information. Their intent was to misinform the public. And I think that's another challenge that we have to face. So it's not just that we have to put out information, but we have to combat people who are intentionally miseducating and misleading the public. And this was a huge problem during COVID. And I think that there was a vacuum that was left for people like that to fill, because CDC and maybe some other government entities really didn't do the best job of communicating if they could. For example, things like calling the operation to create the vaccine Operation Warp Speed, which was about pretty much the worst thing I could think of to call it, which was to focus on the speed that was being used to make the vaccine rather than the care that was being taken. Or even terms like social distance. Social distance is a nonsensical term. It makes no sense. And it's quite the opposite. It's not even what we're asking people to do. During a pandemic, we need social connection, not social distance. We should never say those two words in the same sentence. We need physical distance. So why we were calling it social distance makes no sense to me. I could go on, but I won't with that, especially with COVID. But the reason that people trust Pfizer for Viagra, but they don't trust Pfizer for their vaccine. So the Pfizer is evil. They're evil people, but not when it comes to my blood pressure medications, not when it comes to my diabetes medications, not when it comes to my Viagra, they're not evil, but for the vaccine, they're evil. And I think putting that sort of illogic in front of people's face and forcing them to live with the cognitive dissonance of that kind of illogical, irrational thinking. You know, I found in one-on-one conversations, I was able to make progress with people. But in terms of mass messaging that, I have seen that is a very difficult thing to do. And I don't know that we've really figured out how we can really, on a mass scale, message to people that some of the things like, you know, the vaccine is going to make you a zombie. I don't know how we convince people in a mass way that that's ridiculous. But maybe we need to just continue to have these one-on-one conversations with people, getting them to understand why vaccines make a difference and why vaccines are more effective than leaving yourself vulnerable to these viruses.
More questions from the audience. Building on Dr. LaVeist said, how do we as nonprofit professionals work to make mental health services more affordable? Mental health seems to be one of the few aspects of health that isn't widely subsidized by health insurance or public policy.
I think advocacy. Why isn't it? Ask that question. Ask policymakers, why isn't it? And dentistry, would be the other thing, oral health. You know, why is mental health and oral health not co-equal with physical health? Why is dentistry even a separate discipline? I mean, most things that enter your body enter through the mouth.
The two thoughts that come to mind.
Why is dentistry not even just another subspecialty of medicine? Another conversation to get into. But I think we need to start asking these questions and we need to start advocating. And I think that through the political process, we can advocate for mental health to be treated equally to physical health.
Dr. Baxter, did you have something to add?
I think I had an internet breakup, but I'm good.
Okay. And then our last question from the audience, how can we promote safety and vulnerability among men when so many of us have received messages over time that Black men don't provide a place of vulnerability or safety?
Well, I can start things off. I don't have a perfect answer, and not to go into like a gender norms lecture, but a lot of these things are wrapped up in patriarchy. And patriarchy, as many people know, scholars that are much smarter than me, like Bell, will say that it's not just about, patriarchy doesn't just affect women, it affects men too. It affects the way that we see each other, how we interact with each other. The question you just took from an audience member around mental health, people don't want to show any sort of vulnerability. So that might, you know, make them less likely to engage with healthcare providers, even if they do have access to a provider. So I think the more that we can do as a community across the board to sort of remove some of these myths and sort of deconstruct some of these norms around masculinity. And that's really difficult, as we mentioned before, with misinformation and disinformation. There's social media outlets where people promote this idealized masculinity. We see it in norms that we're not even aware of. Our honoring of athletes and other types of people who, you know, there's always these notions that, oh, you sacrifice your body for the greater good, you sacrifice this, you know, it's all this positive attribution and doing things that are deleterious to your health. So again, I don't have a perfect answer there, but I really think that we have to do the best job we can in our first classroom, our families, all the way out to thinking about different, you know, broader societal norms to try to figure out ways to sort of undermine some of these really toxic norms around masculinity and what being a man is about.
Thank you all. And as we draw near the end of our time together, I'd like to invite each of you to share any final thoughts or comments on today's discussion.
Oh, I'll throw one out. First, I want to say that it is a lie that there are more Black men in prison than there is in college. That is not true. It has never been true. It was a lie the first time it was stated, and it was a lie the last time it was stated. And the reason this is important is because if I said to you, there are actually 500,000 more Black men working on bachelor's degrees than there are Black men in prison nationally. And if you go to the Department of Education website, Department of Justice website, you will see the data for yourself that is the case. So that's a lie. But the fact that people believe that Black people believe that lie is, I think, part and parcel of one of the biggest problems we face. If I said to you that there were more Asian women in prison than in college, you would all think that I lost my mind, and you'd feel sorry for me and say, I'm so sorry, Dr. LaVeist seems to have lost his mind. But if I say that about Black men, people believe it. And it is a huge lie. But if we can believe such a lie about Black men, what does that say when a Black man walks into the emergency department, and how we respond to that person, and how we treat that person, and what kind of care that person gets? That's the last thing I would say about this conversation.
I think one thing that I'd like to say is we live in a capitalist nation. And so as we had this, I think, very robust conversation, I'm glad I have gratitude for this opportunity to kind of have this discussion. We have to remember that, you know, we're living in America, and America is built with capitalism. And so capitalism is attached to racism and patriarchy. And so acknowledging and calling that thing out as it is, I think, is also important. Yeah, I'll stop there.
Yeah, I'm struggling to think of something that someone has not already said. I think that, you know, it's been a pleasure to be here with you all. I hope that people who are tuning in will continue the conversations in their own personal networks, chatting with people, even if there's things that we said that you don't agree with, you know, bring that into a space where you can talk about it with other people. And hopefully that'll motivate people to at least get curious, and then maybe that curiosity will inspire action.
Excellent. Finally, I'll turn it over to Dr. Lydia for closing remarks. But on a personal note, thank you all once again for joining us today in an essential conversation on Black men's health. Your engagement and, again, commitment to promoting health equity is greatly appreciated. And I look forward to us having these continued discussions and working together to create a more healthy and equitable future for us all. Thank you. Dr. Lydia?
Thank you, Marcus, for that wonderful moderation and those wonderful questions. I just have to say, I am so delighted by this panel. I knew it was going to be fantastic and wonderful, because all of these wonderful, smart, fantastic Black men are that. And so it was everything I thought it was going to be and more. I also want to say, I should have said this in the beginning, that I hope the audience saw that this wasn't about telling Black men to go to the doctor. This is about a larger, broader conversation about trends that are happening population-wide and not individual factors, even though going to the doctor is important, as Dr. LaVeist said, and all of our panelists said about insurance and coverage and having jobs. But it was talking about health equities, about the social determinants, about all these interconnected factors that impact Black men's health. And the last thing I want to say is, I love this. Thank you, Dr. LaVeist, for this. You know, I want everybody to leave here and not only, especially ask Black men, but truly ask each other, how are you doing? And how can I support you? So I think Sam, Dr. Baxter's comment about social support, how can I support you in any way that I can, even if it's just a listening ear? It's that joke. It's that way to make you smile. I think that's really important for us to take care of each other as a community and support each other in well-being. And so, you know, there's lots of questions about mental health and stigma, also about talking about people going to therapy, about Black men going to therapy, about Black men talking about the importance of what therapy has done in their lives, and that therapy is a good thing that helps us to support each other, and another self-care method. So thank you so much for these panelists. We're at the top of the hour. I'm so grateful for you and everything that you had to share. And we definitely will continue these conversations, not only within the Urban League movement, but beyond. So thank you so much, everyone. Have a wonderful day, and enjoy yourselves. Take care of each other. Bye.
Thank you.